It is my pleasure to welcome Dr. Anna Garrido-Castro from Dana-Farber Cancer Institute, Harvard Medical School. Dr. Garrido-Castro is an assistant professor of medicine at Harvard Medical School and co-directs the Dana-Farber triple-negative breast cancer working group. She will discuss optimizing the use of available antibody-drug conjugates for metastatic HER2-negative breast cancer, which has become an increasingly complicated question now that we have many ADCs available to use for overlapping patient populations in clinic.
Well, thank you so much. And first of all, thank you to Dr. Sharma, Dr. Klemp, and the organizers for the invitation to be here today. This is my first time in Kansas City. So thank you so much for the warm hospitality. And I will say I am a big football fan. I am a New England Patriots fan, which I'm not sure is any better than Dr. DiMichelle's preferences. But I will say, as a big football fan, I have great respect for the football team in this city. So again, thank you for having me here. And over the next 25 minutes, we're going to talk about antibody-drug conjugates for the treatment of metastatic HER2-negative breast cancer. Here are my disclosures. So we heard a little bit about trastuzumab deruxtecan and some of the new ADCs that are being developed for HER2-positive metastatic breast cancer. And in fact, there's a wide range of different ADCs that are either FDA approved or currently in drug development. You can see here just a few listed in trials for breast cancer therapy, different ADCs targeting HER2, TROP2. You see that most of the payloads of these ADCs are either topo-1 inhibitor or microtubule inhibitors, but there are some differences as well in the construct of these ADCs, drug-to-antibody ratio, and subsequently dosing of the ADCs as well. We know that for the current landscape of ADCs in metastatic breast cancer, there are 4 antibody-drug conjugates that are currently FDA approved, and specifically for HER2-negative metastatic breast cancer, trastuzumab deruxtecan, a HER2-targeted ADC, is approved for those patients with metastatic HER2-low or hormone receptor-positive HER2 ultra-low breast cancer. Dana-Farber deruxtecan and sacituzumab govitecan are 2 TROP2-directed ADCs that also carry a topoisomerase 1 inhibitor as their payload. And sacituzumab govitecan is approved for both the treatment of metastatic hormone receptor-positive and triple-negative breast cancer. And Dana-Farber deruxtecan most recently approved for HR-positive HER2-negative disease. And that encompasses both HER2-low, ultra-low, and also HER2-null tumors. So we're going to dive a little bit deeper into these different antibody-drug conjugates and some of the newer ADCs that are further along in development. And we'll start by talking about targeting HER2 in patients with HER2-negative metastatic breast cancer. And one might argue, well, why do you target HER2 in a HER2-negative tumor? And we know that there is a significant proportion of HER2-negative tumors that in fact have some degree of HER2 expression on the tumor, but not enough to be called HER2-positive. And these have now been classified as HER2-low tumors, defined by immunohistochemistry 1+ or 2+ staining without amplification by ISH. And about 60% of all hormone receptor-positive HER2-negative breast cancers and about 35 to 40% of all triple-negative breast cancers are in fact HER2-low. This audience is well familiar with the data from the DESTINY-Breast04 study that led to the approval of TDXD for patients with advanced HER2-low metastatic breast cancer if hormone receptor positive who had received prior endocrine therapy, and for both hormone receptor positive and negative HER2-low metastatic breast cancer who had received 1 to 2 prior lines of chemotherapy in the advanced setting. And the study met its primary endpoint of improvement in median progression-free survival in the HR-positive group in this trial, which comprised about 90% of patients on study, and also demonstrated a statistically significant improvement in median OS. And that was seen not just in the HR-positive group, but also in the intent-to-treat population and in an exploratory analysis in the about 10% of patients with hormone receptor-negative HER2-low breast cancer, as well, as shown on the far right. And how do we define HER2-low status? Well, we know that essentially HER2-low can be defined by any prior tumor sample, either collected in the metastatic setting or primary early stage setting, that it meets the definition of HER2-low. And in this subgroup analysis from DB04, the authors showed that regardless of whether one looks at HER2-low status in primary metastatic tumor, in a freshly obtained research biopsy or archival tissue, whether it's a biopsy or surgical control specimen that in fact the benefits of T-DXd were relatively consistent across subgroups compared to chemotherapy of physician's choice. Now, last year, we saw the first results from DESTINY-Breast06, and this was a phase 3 study that sought to take T-DXd to a less pretreated setting in hormone receptor positive metastatic breast cancer. And another important distinction with DB04 is that this study not only allowed HER2 low metastatic breast cancer, but also HER2 ultra low. And patients had to have received prior endocrine therapy and no prior chemotherapy in the advanced setting. And the randomization was to T-DXd versus chemotherapy physician's choice, which could have been capecitabine or a taxane. And how do we define this group of tumors that are ultra low? So these are tumors that have faint or incomplete membrane staining in less than or equal than 10% of tumor cells. And about 20 to 25% of hormone receptor positive HER2 negative breast cancer meets that definition of ultra low, really leaving a small proportion of patients with what might consider HER2 null tumor, so clearly no HER2 expression whatsoever on tumor cells. And there are some pathologists who might argue that in fact that there aren't breast cancers that don't have any HER2 expression whatsoever throughout the course of their disease. In DB06, we saw a significant improvement in median progression-free survival with T-DXd compared to chemotherapy physician's choice in the HER2-low population, as shown on the left, with about a 5-month improvement in median PFS. And on the right, in a secondary analysis in patients with HER2 ultra-low tumors, there was a very consistent improvement in median PFS that was also demonstrated in this study. Now, importantly, the overall survival data remain immature at the time that these data were presented, and it is important to note that about 20% of patients so far in the control arm of chemotherapy of physician's choice did receive T-DXd after participation in the study. And I think this is an important point that we will need to keep in mind as we interpret the OS data from several of the ADC trials that are now reporting in earlier lines, in the earlier setting of advanced breast cancer. And we'll talk a little bit more about that as well later on. Now, what this trial also does not address is the efficacy of T-DXd in HER2 ultra-low triple-negative breast cancer or in HER2 null breast cancer. And these questions hopefully will be addressed by the ongoing DESTINY-Breast15 study. Now, switching gears to TROP2, directed antibody-drug conjugates for HER2-negative breast cancer. We know that TROP2 is a calcium signal transducer that is overexpressed across multiple cancer types, highly expressed in triple-negative breast cancer, and also in hormone receptor-positive HER2-negative tumors. There are 2 TROP2-directed ADCs that are currently FDA approved, sacituzumab govitecan and datopotamab deruxtecan for the treatment of metastatic breast cancer. And a third ADC for which we have also seen phase 3 data in triple-negative breast cancer. This ADC is sacituzumab tiromatecan. And you can see here again that all 3 of these ADCs carry a topoisomerase 1 inhibitor payload, but there are differences in that drug-to-antibody ratio, half-life, and dosing and schedule of administration of the agents. Sacituzumab govitecan was approved for pretreated, metastatic triple-negative breast cancer based on the data from the ASCENT trial, which showed a significant improvement in median PFS and near doubling of median overall survival in patients with advanced triple-negative breast cancer who had received at least 2 prior lines of chemotherapy, at least one of those in the advanced setting, so in essence, second line and beyond. And sacituzumab govitecan is now also approved for patients with advanced hormone receptor positive HER2-negative breast cancer based on the results from the TROPiCS-02 study that showed a 1.5-month improvement in median PFS and just over 3-month improvement in median overall survival. And this was a study for patients who had received prior endocrine therapy, a CDK4/6 inhibitor, a taxane in any setting, and 2 to 4 prior lines of chemotherapy for advanced disease. Now, we've seen some data for datopotamab deruxtecan in HER2-negative metastatic breast cancer. We still await data from a phase 3 study in triple-negative breast cancer, but some initial data from the TROPION-PanTumor01 study, noted at the top, show anti-tumor activity with this TROP2 ADC in heavily pretreated metastatic TNBC. And on the bottom, you can see the initial results from TROPION-Breast01, which led to the approval of datopotamab deruxtecan just last month by the FDA for patients with advanced hormone receptor positive HER2-negative breast cancer who had received prior endocrine therapy and 1 to 2 prior lines of chemotherapy. So in essence, a setting very similar to DB04, but encompassing not just HER2 low, also HER2 ultra low and null tumors. And you can see here the 2-month improvement in median PFS that was reported. And just last week, at the ESMO virtual plenary session, we saw the final overall survival analysis from this trial. So the study did not meet this dual primary endpoint of improvement in median OS with datopotamab deruxtecan versus chemotherapy physician's choice. But again, it is important to note that a significant proportion of patients in the control arm, 24%, at the time of the data cutoff, had received a subsequent ADC after participating in the trial. And for most of those patients, this ADC was T-DXd. And we do know that T-DXd does have a PFS and overall survival benefit in that patient population, pretreated HER2 positive, HER2 low metastatic breast cancer. So the authors conducted as post-hoc sensitivity analysis using an inverse probability sensory weighting method to adjust for receipt of subsequent antibody-drug conjugate therapy, and showed that there was a numerical trend favoring datopotamab deruxtecan versus chemotherapy, although this did not reach statistical significance, and this was an unplanned exploratory analysis, so the data need to be interpreted with caution. We'll talk a little bit about the sequencing of antibody-drug conjugates and how we select ADCs in a minute, now that we have multiple options that are available for patients with HR-positive and hormone receptor-negative, HER2-negative metastatic breast cancer. And finally, just a note on SAS-TMT. As we mentioned earlier, OptiTROP-Breast01 was a phase 3 study for patients with metastatic triple-negative breast cancer, a similar patient population to that in ASCENT, and this study was conducted in China, looking at SAS-TMT versus chemotherapy physician's choice in pretreated metastatic TNBC, showing relatively consistent improvements in median PFS and overall survival favoring the TROP2 ADC. And we await data in the HR-positive setting for this TROP2 antibody-drug conjugate there as well. So how do we integrate all of these options now into our treatment algorithm for hormone receptor-positive, HER2-negative metastatic breast cancer? So we know that endocrine therapy in combination with a CDK4/6 inhibitor is currently the recommended option for most patients in the first-line setting. But after progression on endocrine therapy and a CDK4/6 inhibitor, our choice of subsequent line of endocrine therapy does hinge on the results of a somatic NGS testing, where we have different options now with PI3 kinase pathway targeting agents such as pivasertib or alpelisib, and also elacestrant for those patients with ESR1 mutations. But the ADCs, where they come into play, really is in that endocrine refractory setting. So now trastuzumab deruxtecan, based on DB06, is a treatment option for those patients who have progressed on prior endocrine therapy. And one might argue, particularly for those patients who have more endocrine refractory, rapidly progressing disease, visceral disease, considering T-DXd in that space may be reasonable, albeit taking into consideration the differences in toxicity with T-DXd compared to some other standard chemotherapy options that are currently available, such as capecitabine. In the second-line setting and beyond, we also have 2 TROP-directed ADCs that are currently available, datopotamab deruxtecan and sacituzumab govitecan. Not all patients are candidates for T-DXd, and we may consider a TROP2-directed ADC in that small proportion of patients who have HER2 null tumors, who don't have history of HER2 low or ultra low breast cancer. And I think here the selection of TROP2-directed ADC really does depend on the differences in toxicity, an informed discussion with the patient about dosing, scheduling differences between the agents, and how we manage some of the side effects from each of these antibody-drug conjugates, which we'll talk about as well. In metastatic triple-negative breast cancer for first-line therapy, as we know, our choice of initial treatment depends on the results of PD-L1 testing, where for those patients with PD-L1 positive tumors, chemotherapy in combination with pembrolizumab is our current approach. And for those with PD-L1 negative, chemotherapy alone remains the standard of care. A PARP inhibitor can be considered for those patients with a germline BRCA1 or 2, or one might argue also a PALB2 mutation based on the olaparib expanded trial. Now, in the second-line setting and beyond is where the antibody-drug conjugates are currently approved. And here I would argue that there are more robust data for TROP2-directed ADCs in metastatic triple-negative breast cancer. We have data from a randomized phase 3 study, the ASCENT trial, demonstrating PFS and OS benefit with sacituzumab govitecan. And for trastuzumab deruxtecan, the data in triple-negative HER2-low breast cancer comes from a subgroup analysis, an exploratory analysis from DB04 in about 58 patients who were enrolled in that study. So with that said, either option is available for those patients who also have HER2-low tumors, but one might argue that given the robust data of the TROP2-directed ADC, sacituzumab govitecan would be a preferred antibody-drug conjugate to consider in that space. Now, there are multiple trials that are currently evaluating the use of these ADCs in a less pretreated space in the advanced setting. We await data from TroFuse-10, which is looking at sacituzumab TMT with or without pembrolizumab in patients who have received prior endocrine therapy and no prior chemotherapy for advanced disease. And also, we are eagerly awaiting results from ASCENT-07, comparing sacituzumab govitecan to chemotherapy of physician's choice, again, in patients with endocrine refractory disease, but no prior chemotherapy for advanced breast cancer. And in the TNBC space, there are several first-line trials, both for PD-L1 negative and also PD-L1 positive metastatic TNBC, for which we are awaiting results, including in the PD-L1 negative space, TB02 and ASCENT-03, looking at Dato-DXd and sacituzumab govitecan respectively compared to chemotherapy in patients who have not received prior treatment for advanced triple-negative breast cancer, and for patients with PD-L1 positive tumors who are candidates for immunotherapy, TB05 and ASCENT-04, looking at these TROP2-directed ADCs in combination with immune checkpoint inhibition compared to the current standard KEYNOTE-355 regimen. So much more to come in this space. Now, if we look at the differences in antibody-drug conjugates, I do think it is important to carefully balance the toxicities that some of these agents carry. So we know that there are some toxicities that are common across ADCs, including hematologic toxicity, although we do see higher rates of neutropenia with some of the TROP2-directed ADCs on the right, and with sacituzumab govitecan, often we do need to use growth factor support, either short and or long-acting growth factor support while on treatment. There's also GI toxicity to consider, rates of diarrhea with SG compared to some of the other agents. But importantly, there are also adverse events of special interest that we need to monitor very closely for, including stomatitis and dry eye with datopotamab deruxtecan, which does require use of prophylactic eye drops and mouthwash every 4 hours while on treatment with datopotamab deruxtecan, and also interstitial lung disease and pneumonitis, which has been reported with the deruxtecan ADCs, and for which it is very important to educate patients on promptly reporting respiratory symptoms and also monitoring for grade 1 for any occurrence of ILD with regular CTs as well. So what are some of the future directions? Where are we headed? New antibody-drug conjugates, combinations? Should we sequence antibody-drug conjugates now that we have multiple available? And what do we know so far about mechanisms of response and resistance to ADCs? So in terms of some of the newer ADCs for which we have seen emerging data over the past couple of years, patritumab deruxtecan is a HER3-targeted ADC that also carries the deruxtecan payload. We saw some initial promising anti-tumor activity in both hormone receptor positive and triple-negative breast cancer. This ADC targets HER3, and there are additional studies looking at patritumab deruxtecan, HER3-DXd, in patients with HER2-negative metastatic breast cancer. And last year at ASCO, we also saw data for the Nectin-4 ADC enfortumab vedotin, which carries MMAE as its payload. And here I would say that the anti-tumor activity that's been reported is relatively modest, and importantly, also the responses were not dependent on levels of Nectin-4 expression, which we'll talk a little bit about the importance of the expression of the target as well in just a minute. But there is, of course, much interest in looking at combinations now of these ADCs and with different agents, targeted agents, PARP inhibitors, but in particular also with immune checkpoint inhibitors. And the rationale behind this being that topoisomerase 1 inhibitor payloads may potentially synergize with immune checkpoint inhibition because the topo-1 inhibitor can induce cGAS-STING pathway activation, which stimulates T-cell recruitment into the tumor, can also upregulate MHC class 1 and PD-L1 expression in the tumor. And so the hypothesis is that these topo-1 inhibitor ADCs may potentially be better combination partners with immune checkpoint inhibition than standard chemotherapy options, even in patients who have what traditionally have been considered as more immune cold tumors that have not responded to immune checkpoint inhibition. We've seen some initial data for topo-1 inhibitor ADCs in combination with immunotherapy, including data from the Morpheus trial in this arm of sacituzumab govitecan, plus the PD-L1 inhibitor atezolizumab in first-line PD-L1 positive metastatic TNBC. You can see here a near 77% response rate with the combination. And that is very similar to that reported in the Begonia study for datopotamab deruxtecan in combination with the PD-L1 inhibitor durvalumab in the first-line TNBC space. I would note here that in Begonia, these responses seen with Dato-DXd and durvalumab were seen regardless of PD-L1 status. So in fact, suggesting that even in PD-L1 negative tumors, there may potentially be synergistic activity of the topo-1 inhibitor ADC with immunotherapy. And to test this hypothesis, we are conducting 2 investigator-initiated clinical trials looking at the combination of sacituzumab govitecan plus pembrolizumab versus sacituzumab govitecan alone. On the left, in first-line PD-L1 negative metastatic TNBC, where chemotherapy is currently our go-to option. This study is currently open to enrollment. And on the right, SACI-OHR positive, which the results were presented last year at ASCO, looking at this combination of SG plus pembrolizumab in advanced hormone receptor positive HER2 negative metastatic breast cancer after prior endocrine therapy and 0 to 1 prior lines of chemotherapy. And while SACI-OHR positive did not meet its primary endpoint of improvement in median progression-free survival, there was about a 2-month increase in median PFS that did not reach statistical significance, and there was no significant difference in median overall survival, just over 1 year of median follow-up. What was interesting was that in the about 40% of patients on study who had PD-L1 positive tumors, defined using the 22C3 assay in a combined positive score greater than or equal than 1, there was a 4.4-month absolute difference in median progression-free survival favoring the combination of SG plus pembrolizumab, though not statistically significant. And while the data are immature, a 6-month improvement in median overall survival favoring the combination. And so we are awaiting additional follow-up from this trial, but this has also informed the design of TroFuse-10, the trial looking at SAS-TMT with or without pembrolizumab compared to chemotherapy in hormone receptor positive HER2 negative disease. So as we look at the current landscape of ADCs in HER2 negative metastatic breast cancer, here you can see summarized the phase 3 trials that have been reported to date. And a couple of questions do come to mind, including 1, is there a preferred initial antibody-drug conjugate? And I think this depends on multiple factors, but we have seen data emerging in the HR-positive space for trastuzumab deruxtecan, particularly in less pretreated disease with significant improvements in PFS and overall survival and clinically meaningful differences favoring T-DXd versus chemotherapy. And we are seeing T-DXd positioning itself as a preferred initial ADC in the HR-positive space, although we still await data in a less pretreated setting with the TROP2-directed antibody-drug conjugates. Whereas in contrast in triple-negative breast cancer, again, while we have multiple options available, more robust data have been reported to date using the TROP2-directed ADCs, and here we tend to position sacituzumab govitecan as a preferred ADC in this space. And one might question, though, is there a better way to inform our selection of initial ADC, and does expression of the target matter? I think we've seen that the benefits with these ADCs compared to standard chemotherapy are observed regardless of whether or not there's expression, or the levels of expression of the target, I should say. However, we do see that the benefit does decrease with decreasing levels of the target. For example, here in the biomarker DAISY study, the response rates with T-DXd do decrease with the levels of expression of HER2. And while both in ASCENT, TROPiCS-02, and also from SAS-TMT in OptiTROP-Breast01, we have seen that the benefits are larger in those patients who have higher levels of TROP2 expression. Even patients who have low levels of TROP2 expression on tumor cells do appear to derive benefit from the ADCs. But one could envision potentially being able to develop a strategy that helps identify the level of expression of the target, whether or not there's any intrinsic resistance to the payload or internalization of the ADC into the tumor cell that may potentially better inform how we select our initial antibody-drug conjugate. And I think the second question that also comes to mind is now that we have multiple ADCs available and some patients are candidates for more than one ADC, is there a role for sequencing? And if so, how should we sequence these agents? And to understand, to answer to that question, I think we have to have a better understanding of what are the mechanisms of response and resistance to these antibody-drug conjugates. We have seen some initial data from retrospective studies looking at sequential topo-1 inhibitor ADC use. And overall, I would say the take-home message has been that the time to progression on the second ADC tends to be shorter than with the first antibody-drug conjugate. However, there are some patients who do appear to derive the same, if not more, benefit with ADC2 than with ADC1, as shown here. And understanding who those patients are, what is specific about those tumors, is key. There are some mechanisms that have been described. So for example, as was alluded to earlier, emergence of TOP1 mutations, which may confer resistance to the payload, have been described, and these can also be detected in circulating tumor DNA after treatment with the antibody-drug conjugate. And we've also seen that after exposure to ADCs, the expression of the target can also go down. So downregulation of HER2, for example, here after exposure to prior T-DXd. So with that said, there are a couple of mechanisms of resistance to TOP1 inhibitor ADCs that have been more fully characterized, including mutations in TOP1, leading to decreased binding of the decreased action of activity of the payload, and one could potentially overcome this mechanism of resistance by modifying the payload of the antibody-drug conjugate. But also mutations in the gene encoding for the target itself, in this case TROP2, which lead to decreased binding of the ADC to the target and decreased expression of the target on the cancer cell. And one might potentially overcome this mechanism of resistance by modifying the target of the ADC. And with that in mind, there is currently a phase 3 study that is being conducted through the Translational Breast Cancer Research Consortium called the TRADE-DXd study. This is a large phase 2 study with different cohorts exploring the activity of the sequence of T-DXd and at time of progression, Dato-DXd, or vice versa in patients with hormone receptor positive or negative HER2 low metastatic breast cancer. So really testing the hypothesis of can we switch the target of the ADC and overcome resistance if that is the primary mechanism that led to resistance to the initial ADC? And there's a comprehensive biospecimen collection plan embedded into this study with tumor tissue and blood samples collected at different time points to really try to better characterize those mechanisms of response and resistance. But what has become clear is that beyond topoisomerase 1 and microtubule inhibitors, we need new payloads also to address resistance to the payload as well. And there are many different agents that are currently in development, including immunomodulatory payloads, STING agonists, and among others, radionuclide payloads as well that are being explored in different trials. And I think that beyond resistance to the target and payload, there likely are many other mechanisms of resistance to these ADCs, including potentially recycling of the ADCs, mechanisms of resistance related to the internalization, metabolism of the ADC within the cancer cell, even drug efflux pumps as well, and clearly a need to better characterize, to better understand what these mechanisms are to inform the next wave of novel ADC therapy. So with that, here are the key takeaway messages. We now have 3 ADCs that are currently approved for the treatment of metastatic HER2-negative breast cancer that we reviewed today: T-DXd, datopotamab deruxtecan, and sacituzumab govitecan. There are many new antibody-drug conjugates and targeted therapy approaches that are being developed, including new ADC targets, bispecific ADCs as well, with new mechanisms of action, bicycle antibody-drug conjugates, novel combinations as well, including immune checkpoint inhibitors and PARP inhibitors, among others. And ultimately, I hope to have convinced you that understanding the mechanisms that drive response and resistance to these ADCs will be key to help inform treatment strategies, including combination, sequencing, and duration of therapy. So with that, I'd like to thank you all for your attention. I look forward to the Q&A.